everyone. My name is Anna, one of the interns, and today I'll be talking about sedation of the agitated patients. We went over this already this morning due to Christy's wonderful questions, but this will just hammer in everything for you guys. I want to give a thank you to Dr. Delgado, Dr. Panya, and Dr. Raper for helping with this presentation. Today we'll be talking about options for sedation, onset and duration of each agent, risks and cons with each one, how we choose it, and special populations. So let's start with the case. 42 male, past criminal history of bipolar disorder, polysubstance use, diabetes, and hypertension, brought in by EMS after he was found stumbling in a park looking confused. He is currently surrounded by hospital police and getting more agitated. These are his vital signs. What should we do next, or ask the triage nurse? Escalation. Finger stick, I heard, yeah. So get a finger stick just to make sure he's not acting out due to hypoglycemia. So we get the finger stick and it's 115, so normal. The patient is now angrily yelling and pacing on the ambulance triage. You try to verbally de-escalate, but this gets him even more angry. He looks like this. Sedation meds are ordered. You hear, "Doc, I can't pull the meds from the Pyxis. I need you to change the order." So you leave the med student and the intern, you run to CCT, try to change the order. For some reason, the Pyxis still won't dispense meds. You run back, try one more time to verbally de-escalate and offer some meds to calm him down. But now the patient's arms are now flailing, grabs intern, does this. The medical student doesn't want to do EM anymore. What can we do in the meantime if we can't get meds and he's just flailing everywhere? Do we want to maybe make his arms less flaily with physical restraints? Yeah. So the general approach to what we call the ED takedown is you always want to maintain your safety first. Stay 2 arms length away from the patient and never have your back to the patient, and involve hospital police if needed. Also bring the patient to a quiet area. It helps to calm them down sometimes. So you always want to try to verbally de-escalate the situation and do what Tintinelli calls a show of concern. You want to offer them oral or parenteral medication for anxiety or pain. Once you try those steps, then we move on to physical or chemical sedation if the patient is at risk of harm to self or others. There are some ethical and legal controversies regarding physical restraints, but some studies show that if properly done with like a full team approach, it's generally safe without any long-term complications. This is a little picture of how you want to have the patient just 30 degrees head up so they don't have any aspiration. So chemical sedation. The options are 1st-gen antipsychotics, atypicals or 2nd generation, benzos, and a 4th one, which I want you guys to guess, but we already talked about it this morning, so you probably know what it is. So let's talk about 1st-gen antipsychotics first. I'll be talking most about the IM dosing because in these patients, it's typically hard to get an IV in, so you just gotta take the IM and shoot it where you can. So haloperidol, it's available PO, IV, or IM. Starting dose is about 2.5 to 5 milligrams IM, typical onset of 27 minutes and a half-life of 20 hours. And you can see from the pricing up there, it's relatively cheap for the hospital to use. Max dose for this is about 20 milligrams a day. The lesser known one and lesser used now is droperidol. It's an analog of haloperidol. It's available IV or IM, and the starting dose is 2.5 milligrams or to 5 milligrams, same as haloperidol. Has an onset of 11 minutes, so much faster than haloperidol, and a half-life of 2 hours. Even though it's a shorter half-life, it does last about 6 to 8 hours. In studies, it shows that 5 milligrams of droperidol is actually pretty effective in sedating patients, and they don't need any rescue sedation, meaning you don't need to do any additional dosing or add another agent to sedate the patient. And there is a black box warning that was put in 2001 that I'll talk about next, and that's why it's not used so much in EDs anymore. So some of the risks and drawbacks of haloperidol is EPS, as Nadia was talking about. And there's actually a black box warning for IV use. It's not FDA approved for that, and it can actually worsen the possibility of QTC prolongation. It's also not a great single option since it needs frequent redosing, and it's much better to combine with something else like a benzo or something. For droperidol, there was a black box warning in 2001 based on like a small number of adverse events at extremely high doses, but studies show that even up to 10 milligrams can be used pretty safely in the ED. It's not available in most EDs because of the black box warning now, and I don't think we have it here. So next we'll talk about the 2nd generation antipsychotics, and overall there's a decreased incidence of EPS compared to 1st generations, and it offers a more calming effect versus a more sedative effect, so you can still get a history from these patients. The most commonly used is olanzapine, aka Zyprexa, which is available PO, IM, or IV. The starting dose for this is about 5 to 10 milligrams IM, onset of about 30 minutes with a half-life of about 30 hours. And it's a pretty good single agent for acute agitation, and there's lower rescue rates of needing any additional meds. There's also ziprasidone and risperidone, but olanzapine is the more commonly used one. So the downside of this is availability. So I actually called the pharmacy to see if we have it in our ED. She said that it's definitely available in the psych ED, and she's not even sure if it's available in the main ED for use. Another thing is that for IM administration, it needs something called reconstitution, which I had to look up. It means the nurse has to like mix it to make into a liquid so you can use it on the patient. Another thing is that it's more for the admin side of things, but it is pricier than first generation antipsychotics. For olanzapine, it's about like $41 for one dose versus $5 just for Haldol. And also there's not too many studies done on the use in the ED, in the main ED, but in the psych ED, it's used pretty often, and it may cause some adverse events when combined with benzos. So next we'll talk about benzos. There's midazolam, aka Versed, or lorazepam, aka Ativan. Midazolam is available IV, IM, PO, intranasal, or rectal. And the starting dose for IM, it's about 2 to 5 milligrams. Relatively quick acting, onset of 15 minutes for IM, and lasts about like hour and a half. For IV, it'll kick in like 1 to 5 minutes. For lorazepam or Ativan, it's available IV, IM, PO, or intranasal, and the starting dose is 2 milligrams for IM. A little bit longer than Versed, but it takes about 32 minutes to start acting, but it lasts much longer, over 3 hours. If you give it to kids intranasally, it can kick in as fast as like 5 minutes. So the risks and drawbacks is that there's a paradoxical reaction in younger elderly patients. If you use it in this population, it can sometimes cause more agitation versus the calming effect that you want. And there's also small risk of respiratory depression if you're using it in patients who've ingested other depressant medications. So more commonly used as a combination therapy. It's more rapid onset, and it seems to sedate a larger portion of patients at 10 to 15 minutes. The typical combos are haloperidol and lorazepam, haloperidol and midazolam, or B52, which is Benadryl, haloperidol, and lorazepam. The doses are listed up there, but you can change it as needed for the patient. So after we do all this, the patient is still agitated. What can we try next? Which we talked about this morning. Yeah, ketamine. So ketamine. For ketamine, the dosing is actually not validated, but it's usually 4 to 5 milligrams per kilo for IM or 1 to 2 milligrams per kilo for IV. Pretty rapid onset time. For IM, it's 4 to 5 minutes. For IV, it's 2 to 3 minutes. The thing is, it only lasts 10 to 20 minutes, so you need additional redosing for ketamine. It's good to get rapid control of the situation, but it's not a good long-term agent for the entire ED stay since it's so short acting. There is like some concern for respiratory depression, which I'll talk about next. But there is a randomized controlled trial in June that showed that ketamine was more effective in patients with combative agitation compared to haloperidol and lorazepam, and it was actually not associated with any significant adverse events. In this study, they used 4 milligrams per kilo for IM and 1 milligram per kilo for IV. So there are some risks and cons, which is why some ED physicians don't really want to use it as much as the other more studied ones. But there's just not too many studies done on ketamine compared to the other agents. It is basically conscious sedation, so you want to be ready to secure the airway. And there is a higher risk for respiratory depression when you push it IV and you push it too fast. These adverse effects were actually more of an issue during pre-hospital care. There is one study that showed that in pre-hospital care, there's a higher rate of patients needing intubations versus an ED study where they didn't have any higher rates of intubations compared to the other agents. In patients with schizophrenia, it can also exacerbate psychotic symptoms, which is what Christy was talking about. Her patients started growling instead of being more calm. And another thing is that it's also up to the comfort level of nurses. So some nurses are not used to administering ketamine for agitation, so they might give some pushback, which is what I heard in our ED. But other EDs, like at Brookdale, apparently they use it pretty normally for in the ED. So here we have the onset times for each agent. Ketamine is the fastest, as you can see, 5 minutes. Droperidol, not as much used, but it's pretty fast onset to 11 minutes. And out of all the ones we normally use in the ED, you do see that Versed is the fastest onset for about 15 minutes. And the other agents, haloperidol, olanzapine, lorazepam, all about the same time. So how do we choose which one we want to use? I've been told that people have strong opinions on this, but this is just straight from Tintinelli's. So for second generation, it's actually preferred over the first generation for elderly patients and patients with known psychotic disorders. And it's also good for agitation associated with delirium. But like I said before, it's not as readily available in EDs unless you're in the psych ED. First generation is good for patients who took any CNS suppressants like alcohol. And there is actually a black box warning for dementia-related psychosis in elderly patients. But for those patients, if you have to use a first generation, just use low dose, usually half dose. Benzos are good for undifferentiated patients or patients in alcohol withdrawal or anyone that took CNS stimulants like cocaine. And it's good for patients with anxiety too. And ketamine, it's fastest onset. So you also want to think about the special populations, such as the elderly, pediatric patients, or pregnant patients. For elderly patients, you want to give half dose of meds, and you also want to give a slower redosing. And you also want to be mindful of polypharmacy. Since most elderly patients are either taking like QTC prolonging medications already, you want to be more careful about giving some antipsychotics, which is why we give a half dose. And you also want to avoid benzos and anticholinergics in the elderly. For pediatric patients, most of the time, agitation is caused by dehydration. So you can just try giving them fluids and see how they react. Or you can just give them Benadryl, put them to sleep, and calm them down. If you do want to give meds, you always want to give oral first, and then IV, and then consider IM. For pregnant patients, you want to give Benadryl first, pretty safe in pregnancy. And all the drugs we talked about today, all the antipsychotics, benzos, it's relatively safe for like a one-time dose in the ED. And most of the adverse effects are usually with like long-term usage. And for them, if physical restraints are needed, you want to lay them left lateral decubit so you're not compressing in the IVC when they're supine. All right, so the case, the nurse was finally able to get the drugs. Patient was given 5 milligrams Versed, sleeping like a baby. And summary, you just want to maintain your own safety first, and you always want to try to verbally de-escalate at least twice before stilling the patient with any drugs. Physical restraints and chemical sedation are when patients becoming more harmful to themselves or to the staff. And you also want to take into consideration the type of patient and the cause of the agitation for the chemical sedation. These are the references. Any questions or comments?